for taking your time. Thank you for taking your time and your commitment to this council. BHA appreciates you. For those of you that may be joining us from the public, I am Megan Shelton, Director of Strategy, Planning, and Engagement, and I oversee the Behavioral Health Administration Advisory Council. And so with that, I will pass it over to our chair this morning, Tasha Konkar.
Good morning. Good morning, everybody, council members and members of the public. Welcome to May 2025 Behavioral Health Administration Advisory Council meeting. I am going to call to order this meeting. Do I have a second? Or do I need a second? I don't know.
I second that we're calling it to order.
Thank you, Carolyn. All right. I'm going to go ahead and call roll call right quick, and then we will go over today's agenda. So on roll call, Karen Renee Anderson, she is excused for today. Danielle Ngati, Dr. Rob Archuleta is excused for today. Preston Berry, Whitney Butcher,
Present.
That was kind of cool. Ash Castro, Raquel Garcia, our chair is excused for today. Carolyn Hall,
I'm here.
Tasha Conker's present. Judge Elizabeth Leith,
Present.
good morning, Judge.
Good morning.
Maria Martinez, Keith Parker,
Recording in progress.
I see your hand there, Keith. Keith is present. Antonio Pito,
Yep, I'm here.
good morning. Nor Shafee, Jamie Ulrich,
I'm here.
good morning, Jamie.
Good morning.
Cameron Vigil is excused for today. Catherine Washington,
Good morning, President.
good morning. Seth Watkins, Swaylin White Skunk. All right, let me pull up the agenda for today so we can get this meeting started. Do we have quorum, Megan? I think we're shy by 3. Give us
Sorry,
one.
I was just
You're
on mute.
fine.
Tasha, I'm only counting 9. How many are you counting?
That's what I'm counting as well, too.
Okay. So for quorum for this meeting, we do need to have 10 members.
Okay.
I say let's give it another minute and see if we have one more person join us.
All right. I will go ahead and then go over the agenda just to give us a little bit more time.
Yep, that sounds
All
good.
right. So in today's meeting, we're council debrief for the grievance insights, or for the grievance system, the insights and timelines. We're going to go over that for the debrief. And then council administrative review. We have a recruitment update. We also have the report subcommittee recruitment needs, and we'll go over that. And then we also have an item on the agenda to move June 19th meeting to the week before because it is a state holiday. It's Juneteenth. And then we have a wonderful presentation from Megan Shelton and her team for the Bosso Regional Subcommittee presentation. And then at 9:45, we're going to take a break. At 9:50, we're going to have a presentation from HICPUF and Medicaid presentation. And then at 10:25, we will be open for public comment. So, Megan, would you like to go over the meeting requirements? I totally spaced it. Sorry.
Yes.
Thank
Calandra,
you.
if you can share the meeting packet, we'll go
Oh.
through that and we'll check for quorum one more time.
And
Oh,
Danielle and Gotti's here, so we do have quorum.
okay.
We should.
Perfect.
Yep. Thank you.
All right, let me just double check on participants. I'm just going to confirm that we have 10 now. Perfect. Danielle, you just saved our day and our meeting, bringing us to quorum for our advisory council.
Sorry, I have a junior with chickenpox, so my life's a little discombobulated.
No apologies. You had perfect timing. Thank you, Danielle. Okay, all members of BHAAC received last week the BHAAC meeting packet. It is also on our shared drive, so you can access that at any time. We welcome all members of the public who have joined our meeting today as well, and want to note that closed captioning has been enabled for this event. And if you are having any access issues, you can reach out to me directly. I will also put my email in the chat if you don't have access to the meeting packet right away. And if you want to go down a little bit, Calandra, I just want to quickly review our group agreements for this meeting. You can use the Q&A feature. We also have a public feedback and questionnaire form. We do public questions during the last 5 minutes of the meeting. And so if you are joining us from the public, please hold your questions until then so that we can prioritize the work that the council is doing this morning. This meeting is recorded and can be found on the BHA website. And members of the council have agreed to a code of conduct. We recognize that people will have differences of opinion, but to always be respectful to one another at all times. If you want to scroll down a little bit, I think we've covered all of that. And then the rest of the meeting packet covers engagement, attendance, and examples like today. Super important for members to attend all meetings. We have so much that we cover in these meetings, and we can't move forward without quorum. So very grateful that we have that today, and also very understanding that many of our council members have other commitments. It is the month of May where everything throughout the year seems to be wrapping up. And so folks are pulled in lots of different directions. Okay, and with that, I will pass it back to Tasha.
Thank you, Megan. All right, so it is 9:09, almost 9:10. The council debrief, review of the grievance system. Oh, do we need to approve minutes first for April's meeting minutes. So
I make a motion that we approve the meeting minutes for April.
Thank you, Carolyn. Can we get a second?
I'll second.
Thank you, Jamie. So with that, April's meeting minutes are approved. Where's my little gavel? Thank you so much for that. Now we're going to go into council review for the grievance system. Megan, can you help me out with that a little bit? You're on mute. Thank you.
Thank you, Tasha.
You're welcome.
Yeah, so slides are up and we'll slowly roll through the slides. This is the presentation that you all had with Stephen Ma and Rochelle Gailey from our quality and standards team on our grievance system. And so this slide kind of has the folks that spoke to you all, and then we can go to the next slide. This is, if we want to pause on this one, these are projects that the team has completed. And so they reviewed all of this with you all during the last meeting. Okay, and we can continue to move
Thank you.
along. current projects that they are working on. They're working on updating the complaint form to gather identified data points, updating the complaint form to use plain language, addressing a large increase in complaints and critical incident reports, and finalizing an internal grievance and complaint standard operating procedure for the complaint team. And I will flag that the plain language that has always been brought to our attention by this council. Of every time people do presentations, you are very very good at flagging anything that we are creating that doesn't have plain language. So thank you for that. Thank you for always being our eyes to redirect that and make sure that we are communicating in a way that all people of the public can understand. This next slide covers their upcoming projects, communication regarding client rights and how to file a grievance, training and regional engagement specialists, informing qualitative metric tracking, publishing data in various types of resources, grievance posting template for providers and consumers, and complaint report document to update to better define investigation outcomes. So just raise your hand if you have any questions on any of these, any comments that you wanted to share in response to the follow-up from the presentation from April. If you want to pause on that slide for how to file a complaint, I think this one is really important just to review that complaints are confidential and can be anonymous. BHA protects your identity. You can submit a complaint online, and the address to do that is right there. The phone number is on there. You can also email the BHA complaint line, or you may send the complaint directly to the BHA office, and the address is listed there. Caroline, I believe I saw your hand, and then it came down, and then Tasha, I see yours as well.
Oh, so what I was just going to say, hey, is there somebody that can walk them through if they're not computer illiterate, but there's a number here that they can call.
Oh, perfect. Okay. Thank you, Caroline.
Amazing point, Carolyn. Thank you so much for that. My question that I had that came to mind when we were going through this is this just the file complaints for the entities that are registered with the BHA, or is this for all complaints when it comes to these services, or with mental health and substance use?
We receive all complaints and then direct them. Yes.
Thank you so much for clarifying that for us and the public. Appreciate that very much. And if there's any additional, Carolyn, go ahead. You have a question?
Yeah. So I do. What I'm curious about is is there a time frame for a grievance to be totally completed? And does the person that filed the complaint, if they're not anonymous, will they be able to learn results and how it was resolved?
Those are great questions, Caroline. Sammy, can you make sure to capture those questions in the minutes?
Absolutely, I will.
Thank you.
And we will make sure that these questions that we have will get answered and followed up on. So thank you for those questions. And we're working on other questions to follow up for those. So does anybody else have any concerns, questions, comments about the grievance system at this time? All right. We got 5 more minutes can we jump a little bit? Can we move on, or should
we can move on, Tasha? Yeah, I think
we have a little bit more council administrative reviews that we have to go over and some information. So I think that, yeah. All right. So next on the thing, I'm doing good on my ums. Sorry. So council administrative review, recruitment update. July 1st, at the inaugural term, our team council, our term ends. So we're going to be recruiting for the second term for this council. We have 64 total applications, and with that, we need to get together, and the executive team is going to go through the applications and present the applicants to the council in June's meeting. Correct, Megan? Is that what we discussed?
Yes. So
For a vote?
within the next couple of weeks, the executive committee will get together. They will review all 64 applications that have been received. And then they will put together their recommendations and present it to the council at our June meeting, so that we can get
Letters of
we can notify all new members and get their letters of commitment signed by July 1st for the new term.
And this also includes any current members that reapplied, for them to sign their commitment letters too and be reappointed as well.
Absolutely.
Yeah. So we will be going through that. Let's see.
I see, Clondra, you have a question.
Thank you.
I just wanted to ask a question as a community engagement specialist. I have been promoting the BHAAC Council and was really hoping to get more representation from the Northeast. That's all up to you guys. I'm not campaigning for anybody, but I was hoping that y'all have a plan for letting folks who applied know that they have not been selected, because I've had a couple of folks reach out and they're really excited about this and just would like to let them know that, what the decisions were.
That's a great point. Thank you for bringing that up, about letting the ones that know that if they weren't selected, how that goes. So, Megan, would you like to add on to that?
Absolutely. And that we will make those notifications by the end of June. Sometimes it can take a little bit of time once we make our final selection. If there's a chance that someone does not accept after they've been offered, then we want to still have the opportunity to go back to the applicant pool. But they will be notified one way or the other. And so if they are appointed to the council, they will be notified after the membership has been voted on in the June meeting. And so in that last 2 weeks of June, they will be notified if they have not, if they were not selected.
Thank you.
And then, I don't know, I wanted to bring this up in just for public information. The regional subcommittees, is that up to apply? Like, if they don't get accepted to BHAAC, can they apply for the regional subcommittees?
Absolutely, Tasha. We are actually trying to look at where we put that on the agenda. So we are going a little bit later. Actually, after this section of the agenda, we have a presentation on the regional council. And so I will talk about how to apply for that and what that will look like. I will also mention to you all, because I will be needing to lean on our advisory council for this. BHA is going to be running the recruitment for the BASOs for the inaugural BASO regional councils. And so we are going to run that very similar to how we run like an RFP review, where we'll have a team of people dedicated to reviewing the applications for each council. And so on that team, we are figuring out the logistics for that, but it will likely be a couple of BHA team members. It will be BASO representative, a member of a health and human service agency, and I would love to have a BHAAC representative helping to review those applications for each region. And so I will share more information with you all on that during our June meeting as we work out those logistics. The applications will go live June 1st, and there'll be that folks can apply through August. And then the review will be in the first 2 weeks of September. And so to answer your question, Tasha, anyone is welcome to apply for those regional councils. When we get to that presentation, I'll go into a little bit more detail with you. Statute does require very specific membership seats and representation on each of those councils.
Thank you for that. All right. We got 3 more minutes. So before Megan gets to present, report subcommittee, I want to just briefly touch on that. We're still in need of 2 more members to be a part of that subcommittee. This is the time with this report. It's our chance to have our voices and the people of Colorado's voices heard at the table. So it's really, I can't stress how important it is for people to be involved in that, so we can continue to serve the people of Colorado the way that they deserve to be served. So on that note, I just want to put that out there. Next item of business is
Tasha,
yes.
can I jump in and just
Yes,
ask
go right ahead.
directly if there are any members here with us today that would like to join that committee?
Can we sit on both?
Both as
The advisory as well as be a representative for the regions?
no, I meant for
Okay.
the report writing committee that you were just talking about.
Sorry. Is there anybody that hasn't applied that would like to be a part of it? Carolyn, you're on mute.
Already applied, but keep me in the loop, okay? Because I want to do what I can.
Yes, absolutely, absolutely. And Keith, you have your hand up.
Yeah, I think that I put in for that committee. I would like to be on that committee if that's possible.
Okay, we'll make sure that we put your name down. So when that comes about, we can send out information.
All right, thank you.
Thank you.
Tasha, Catherine also put in the chat
Thank you.
that she would like to be on it as well.
Yay, Catherine! Yay! Thank you, guys. I appreciate that. Yeah. And going forward, we will be in contact when we get all the people together and get that ready to get started. We'll send out emails and be in communication with that. Now, big item of on the agenda today that we need to take a vote on is our June's meeting falls on Juneteenth, which is a state holiday. So I don't know who really wants to work on a state holiday. So we have talked about this in thinking about moving June's meeting to the 12th, the week before, the Thursday before June 19th. Anybody have any questions, comments on that? And we need to take a vote to see about moving that meeting so it's official. So if there's nobody that has any comments or concerns about that.
I just
Yes.
I won't be able to make that meeting because I already have something scheduled that day.
Okay. Thank you for letting us know, and we will definitely thank you for letting us know beforehand, and we will definitely make sure that you are in the loops with communication with that. So for that note, I'm going to put a motion on the floor to move June's Behavioral Health Administration Advisory Council meeting to June 12th. We can all raise our hands or virtual hands, whatever hands you want to do, that would be great. And hold them up for a little bit so we can get count. 2, 3.
Tasha, while you're counting, I just wanted to comment to Judge Leith that we will send out the list of applicants to our council the week before that meeting. So you'll be able to weigh in on those members as well, since the council will be voting then at that next meeting on the new membership. So you'll still have that opportunity.
Thank you. Thank you. I counted all the hands. The only ones I didn't see there. Oh, there's Maria and Antonio. Can we get your vote, please? Somebody check the chat for that, please.
I don't see anything.
I'm trying to figure out how to do that.
It's okay.
Maria said yes, so that's 5, 6.
And Antonio,
Maria.
you can verbally vote too.
All right. Yes.
Okay. But with that, it is at quorum. We met quorum, so June's meeting will be moved to June 12th, 2025, at 9 a.m. Thank you. All right. Now, great presentation. I love to introduce Megan Shelton and her team to present on the BASO regional subcommittees. Take it away, Megan.
Thank you, Tasha. Calandra, do you mind putting those slides up, please? Danielle, I think your hand's still up from voting, or do you have a question? Okay. All right, you all. So I am excited to share a little bit more with you about the regional councils for the BASOs. I know you all have had a lot of questions. I've given you pieces of information, but today should hopefully clarify any additional questions that you have. We can go ahead there. Thank you. And so as you are aware, 2765-703 is the specific statute that calls out that the BHA shall create a regional subcommittee structure as part of the Behavioral Health Administration service organizations, the BASOs, to promote local community input pertaining to behavioral health service needs. And so this is required through statute, and there will be 4 regional councils. There will be 1 regional council for each BASO. And this allows us to increase the precise community input and public participation in each region. Next slide, please. So the first phase is the creation of the councils and how they will be organized. And as you all are aware, Caitlin Long, our boards and commissions coordinator, worked very tirelessly, put a lot of commitment into aligning all of our boards and councils with similar structures, compensation, bylaws. There's actually a whole toolkit for how to run a council. And so all of that information will be given to the BASOs to run the councils, very similar to how this council, as well as BHAAC, the Mental Health Advisory Board, and CYMHTA are run. And the structure that we've put together helps us to determine what services are needed to establish a full continuum of care. It allows us to address barriers to individuals accessing quality and timely care, and it helps us to identify the needed specialty services for priority populations within each region. Similar to how this council runs, the regional councils will have a direct feedback process with the BASOs, and they will produce an annual letter of recommendation that will be due to their BASO by September 1st of each year. So very similar to what you all do for BHA. The letters of recommendation shall analyze the statutory requirements and make recommendations for their respective regions. BASOs will also incorporate these letters of recommendation into their annual report that is due to the BHA by September 30th of each year. Additionally, statute requires that BHAAC, or through statute, BHAAC has proposed a direct feedback process with the regional councils through quarterly updates that summarize what's going on within each of the BASOs. And so that has been a direct request from you all that we will ask them to provide quarterly feedback to our council. Okay, so phase 2 is what I was speaking about a little bit earlier. This is the membership recruitment application and appointment process. We are currently in the phase of putting together what all of that will look like, having all of the pieces. finalizing the applications that will go live in a couple of weeks on June 1st. And so this slide is the one that I was talking with you all about a little bit earlier, is that statute is very clear in the seats that need to be filled and who they're appointed by for each of these regional councils. And so the first one is an individual with expertise in behavioral health needs of children and youth. And this seat is appointed by a local or regional public health or human service agency within the subcommittee's region. The next one is an individual that represents a behavioral health safety net provider that operates within the region. This one is also appointed by a regional public health or human service agency within the region. A county commissioner of a county that is situated within the region. This one's appointed by BHA. One individual with a connection to a K through 12 grade school district within the subcommittee's region. This one is also appointed by a regional public health or human service agency within the region. An individual with criminal justice system within the criminal justice system within the region. And this one is also appointed by a regional public health or human service agency within the region. An individual with lived experience or a community member who is not also a behavioral health provider appointed by a regional public health or human service agency within the region. And so you'll see there's 5 positions that are appointed by public health or human service agencies. And then additionally, 1 individual with lived experience appointed by BHA and 2 individuals with lived experience not associated with a behavioral health treatment provider appointed by the BHAAC. So 2 seats appointed by BHA, 2 seats appointed by the BHAAC, and the remaining seats are appointed by public health or human service agencies within the region. And so what I was describing to you all earlier with having a review committee, that is why we would have a full-on inclusive committee that would have representation from the BHAAC, representation from public health or human service agencies. There could be 1 or 2 on those. We're still working out some of those details to get the right team reviewing the applications. I do anticipate with having 64 applicants for this council, I anticipate a fairly similar outcome. I think we'll have quite a few applicants for each of these. And so want to make sure that we have a smooth and efficient process and that we are really working. BHA is committed to ensuring that we have a very diverse council for each of the BHAAC regional councils. Caroline, I see your hand.
Yeah, I have a question. Like I've done a lot of work in the past on Region 5 and then the combined regions of 3 and 5 in the past. And I would really like to continue. And so I applied through Access through Becky to work the council for. So what I wanted to know, it looks like there's 9 councils or 9 people that will be on this committee. Will there be additional like people with lived experience in that or who are utilizing services?
So each of the BHAAC regional councils have those 9 seats. And then as you'll see, several of them are lived experience seats. This is for the inaugural council, and I anticipate changes may come in future years that would require statutory changes to have additional members. The way that statute calls out, it's very specific to those 9 seats representing each of the councils.
Thank you.
So similar to our council, members will serve 3-year terms, except for the initial terms it may be for 2 years. BHA appointed seats will be the 2-year terms. And the reason we're doing this is to intentionally create overlap and ensure members do not term out at the same time. Similar to what we've learned from this council, we want to make sure that we're keeping, we always have some members that have been part of the council before, so it doesn't have a complete turnover. Tasha, I see your hand.
Yes, to the subcommittees. I'm just curious to know how the regional subcommittees and the advisory council are going to play together. I said play together. How they go hand in hand and how it works up the chain. And are they in? Is the regional subcommittees going to be a part of writing the report, or are they just writing recommendations to give to us to put in the report? How's that all work?
So Tasha, the BASO regional councils are writing their own report to their own BASO. Additionally, they will have feedback, whether that's writing a report or coming to a quarterly meeting to share with BHAAC. But that is separate from the work our council is doing. I think it can inform it, creates that collaboration, but it doesn't change what we're putting in our report.
Thank you for that. I appreciate that.
Absolutely.
And Jamie has a question. Jamie?
Thank you. Megan, I have a question on your previous slide, 9 on membership. And when you talk about being appointed by a local or regional public health or human services agency in the region, is the BASO selecting the agency that gets to appoint the members, or how do we know which public health or human services agency is appointing the members?
That
Does
is a
that make
great
sense?
question. Yeah, absolutely. We were just
Okay.
talking about that yesterday. So, Jamie, that's one of the things we're still working through. I know there are a lot of public health and human service agencies within each region. And so, still working through how that is identified, and if that is having folks apply for the review committee and then they're part of the process, that all of the recruitment will be in very strong, although BHA is doing the recruitment, it will be very strong collaboration with our BASO partners on being able to select both who's on the committee and then who's doing the appointment.
And then, thank you. So if the applications are live June 1st, when will we know which agency is selecting the membership? So for example, if not that my agent, because we have a big BASO region, but if let's say Weld County government was selected as either the public health or human services agency that maybe would be appointing.
Jamie,
do you know what I'm saying?
I don't know if it's on my end, but I did not hear what you just said.
Can everyone else hear me?
Yeah, you cut out a little bit.
Okay. I'm just saying, how soon are you going to know which the agencies are so that people know if they should or should not apply if the applications are available June 1st?
I think that's a great question. One of the ways that I'm looking at this, Jamie, is really getting the applications out to everyone, not limiting it to you can only apply if you are connected to this regional public health or human service agency. What I anticipate is we will be able to look at all of the applications and they will be able to select what seat they're representing. And then we can make those recommendations to specific regional public health or human service agencies that they might be connected to make those appointments. This part's complicated. I will completely own that. And figuring out how to do this is a little bit challenging. So if you have any ideas you want to share with us, Jamie, as we start to figure out how, like, that piece is, I think, the biggest challenge to make sure that we are putting our process together in a way that does allow applicants from all over the state. I don't want anyone to feel like they're limited or they can't apply because they're not connected to a regional public health agency.
Yeah, I think that's challenging. I wonder if it would be worth going through the associations. So I know that like public health has an association. We have, when we talk about county commissioner appointment, we have CCI that can maybe appoint. We have CHSDA, Human Service Directors Association. That might be an option to funnel those specific appointments through the associations.
Okay, that's a great idea, Jamie. And that's on my list for updates for next week with the county directors and I'm not saying it right, CHSDA. I know I just didn't say that correctly. CDHS. No, I'm not going to try anymore.
Those
CDHS,
acronyms.
but also CHSDA. You did say it right.
Oh, I did say it right. Okay,
Yeah.
CHSDA. Yes.
What does CHSDI stand for? So, because those acronyms. So,
sorry.
It's okay.
CHSDA is the Colorado Human Services Directors Association.
Thank you, Jamie. I appreciate that.
Yeah. And CDHS is Colorado Department of Human Services.
Thank you for the transparency there. All right. It's 9:43. I just want to do a time check. We got 2 minutes, Megan, before we take.
Okay. All right, Calandra, let's go through the rest of these slides. Okay, we can skip to the next one. This is our timeline that I wanted to review with you all. So we are in the prepare phase currently. We will enter into the educate and recruit phase beginning in June. Applications will go live on June 1st. And we will be getting the word out through newsletters, social media, all of our avenues, pushing it out that this is an opportunity and explaining what it is. Additionally, in July, we've put together an engagement plan specific to recruitment for the BHAAC regional councils. And so every Monday in July, there will be a virtual meeting. One is dedicated to each region. Our BHAAC partners will join us for those virtual sessions, and those will really be an educational opportunity to highlight what a BHAAC is, how a BHAAC functions, and then this opportunity to be involved in informing the work of the BHAAC. And so it really will be going through and educating what does it mean to be a council member, what are the responsibilities, what is the commitment, what is the purpose and the function, so that it's very clear that when people are applying for it, they know exactly what they're getting into, and they know exactly what the role means and how it functions and what the commitment is.
Awesome. Thank you. Also, I just wanted real quick, there was a question, or there was a statement put in our chat. There was a question that was asked. I think that's back when Megan Lovelace did that. I'm just curious to see if there was ever an answer to the question that they asked when the bill was ran around DHS selection.
I don't know if I'm understanding Megan's question.
Can we wait? Do you want to wait till public comment for that?
Yeah, let's wait till
Okay.
public comment. And then Megan, if you can clarify.
Would you like her to come off mute and speak, or just do that in the chat?
We'll have her come off mute when we get to public comment.
Okay, sounds good.
All right.
And then, go back to that slide real quick, Calandra, sorry. So wanted to finish going through the timeline. I know I have 1 minute, Tasha.
You're fine. You're fine.
So September is when we'll be reviewing the application. So the first 2 weeks of September will be the review committees reviewing the applications and making those recommendations to Commissioner Smith. She will have a week to review them. And then the applicants will be notified of their appointment. And they will be notified by October 1st, and their letters of commitment will be due October 15th. And so then we'll work with the BHAACs along this process to make sure that they're establishing meeting cadence. And that piece will take place once the members are in place. The BHAACs will work with the council to determine when they'll meet and all of those things, similar to how this council did at the very beginning. Okay, now next slide. And we can go to the next one. And so this really just highlights all of the toolkit that BHA has put together for our BASO partners. And so we will be giving them templates for the council bylaws, for agendas, for meeting minutes, code of conduct, an ethics handbook, conflict of interest form, letter of commitment template, slide deck template, recruitment strategies and materials for when they fill seats after the inaugural council, and then communication protocols and direct feedback processes that BHA follows for all of our councils. In addition, we will also be giving them training materials that detail the council's functions, members, roles and responsibilities, and applicable laws that impact the councils. Are we over time, Tasha?
Yes, we are. We have 3 minutes till Hick Puff is supposed to present.
Okay, I think we can wrap up here. These were the most important pieces that I wanted to share with you all. So this is the final, the engagement for the BASOs. Those will be in July. And so we can, Tasha, I'll let you move us into our break.
Yeah. Is Hick Puff ready? Are they here? Are they ready? I don't know, because I know we went over 3 minutes for our break time. So
I think you can still go ahead and give the council a 5-minute break.
okay. All right. Sounds good. So we're gonna take a 5-minute break, guys. It is 9:48, so come back at 5:53, I think is what would make it, I think, or 5:55 or 10 by 8:55, 9:55. Jeez. All right. Yeah, so come back and we'll see you guys here in 5 minutes.
Okay, thank you, Tasha.
Thank you. We just want to do a time check. We got 1 minute remaining. All right, members, if we can start making our way back from break, so we can engage in this amazing presentation from HICPUF.
Thank you for bringing us back in on time.
Thank you, thank you. So our next agenda item is our presentation from HICPUF with Medicaid. Megan, I don't know if you want to introduce them or me just kick it over to them.
Thank you, Tasha. I believe that Matt Sundin is presenting to us today. Matt is the ACC Program Manager, Section Manager with HICPUF. So Matt, I will pass it over to you if there's anything else you would like to share for your introduction, and then the floor is all yours.
Thank you, Megan. Yeah, my name is Matt Sundin. I'm the Program Management Section Manager in the ACC division here at HICPUF. So our division is responsible for forming and managing contracts with our RAIs and our MCOs, who are sort of the leads in implementing Medicaid throughout the state. I'm joined today by Katie Lenigro, who does a lot of our communication work for the ACC division. So Katie, if we go to the next slide, really our presentation is going to cover a couple things. We'll give you some information about the Accountable Care Collaborative. I think a lot of you are pretty familiar with the ACC, but just want to make sure we're level setting and talking about what we do with the ACC. We're going to talk about care coordination, which is a big function within the ACC, and also how we're collaborating with BHAAC and how our RAIs are collaborating with the BASOs. And then finally, talk a little bit about supporting rural access to care and how the ACC program is doing that. So Katie, if we go to our next slide, we're going to start off by talking about our Accountable Care Collaborative, or the ACC. So the ACC is the main mechanism that we use at Medicaid to really implement the state Medicaid program and provide services for about 1.2 million Coloradans. We use the ACC to make sure that our programs supporting Medicaid are cost effective, that we're providing quality services to our members. And really the goal of the program has always been and continues to be to improve the outcomes in the healthcare of our members. Through the ACC program, we're coordinating not only behavioral health services, but physical healthcare services, so that when our members are interacting with Medicaid, they're getting full healthcare and getting all of their needs met. And really our RAIs that we contract with are responsible for coordinating that care across all the different modalities and the different types of care. You'll hear a lot about ACC Phase 3. And that's really the program that is going to go live for us on July 1 of this year. So we're about 50 days out on that. Already we've been working very closely with our RAIs to make sure the program goes smoothly and that our members and our providers don't notice any sort of gaps in their services and that everything goes smoothly. So Phase 3 refers to the period that begins July 1 of 2025. If we go to the next slide. We keep talking about RAIs, or regional accountable entities. And those are really the prime entities that we work with, along with managed care organizations, to implement our program. There are a number of different responsibilities that our RAIs have. The first is to build a network of providers, both on the behavioral health side and on the primary care side. So RAIs contract with primary care medical providers, or PCMPs, just within their own geographic regions, but they contract with a statewide network of behavioral health providers that administer a capitated behavioral health benefit. So we pay the RAIs for both. The way that we pay the RAIs and the way they distribute the funds differ depending on whether it's a primary care medical provider or a behavioral health provider, but the RAIs have responsibility across both systems. The RAIs also have responsibilities for care coordination. So they are supposed to work with members to make sure the members are receiving the appropriate services and the services that they need to have better health outcomes. So they do that through care coordination. There are condition management programs that they implement. They provide case management services. The way the RAIs do this can differ per RAI. So some RAIs have their own centralized staff that do a lot of the work. Some of them delegate out or subcontract out the work. But all of the RAIs have the same responsibilities under our contract. Additionally, RAIs are responsible for working with providers and making sure providers are well-versed in Medicaid. They know how to interact with the state Medicaid program, and to make sure that providers are doing things to improve their work or enhance their work with our members. So these include things like supporting our PCMPs with technical support. They will support their work with data or their usage of data. They've been working with PCMPs to integrate the primary care and behavioral health functions within their office. So that's another prime function of our RAIs, and that we're strengthening in ACC Phase 3. In addition, all of our RAIs, we focus on regionality with our RAIs, in understanding that a lot of our healthcare solutions are better done at the local or regional level than they are done at the statewide level. And because we really believe in that regionality, we ask our RAIs to support the regions. We call it their health neighborhood, but all of our RAIs invest additional funding into the regions to make sure that not just providers, but other entities in the regions are serving our Health First Colorado members. We go to the next slide. Katie, I'm not seeing, oh, there we go. So why is the ACC and why is ACC Phase 3 important to all of you? Well, as I mentioned at the outset, the ACC is really our primary tool that we use to implement Medicaid throughout our state. It's the primary delivery system, and we use managed care strategies to maximize our support for our members. So we can do things in managed care that you can't do in a strict fee-for-service basis. So if everything came just to the department, providers just billed to the department, we wouldn't have all the resources we need to serve our members. By doing it in a managed care function or a partial managed care function, we free up resources that we can use to support our communities, to support our providers, and most importantly, support our members. And so the ACC is that tool that we have approved by the federal government to use within our state to really maximize the dollars that are coming into our state to support our members. So ACC Phase 3, which again kicks off in July, really builds upon what we did in ACC Phase 1 and Phase 2. We decided with this round, we weren't going to just totally rip up the old system and try to reinvent it, but build off all the lessons that we learned in ACC Phase 2 and modernize our delivery system. So a couple of things that we did that were really critical. First, we expanded our expectations for the RAIs and our PCMPs around care coordination. So while care coordination was a key function in ACC Phase 1 and Phase 2, in Phase 3, we really strengthened the responsibilities here. We did some tiering of our population and added additional responsibilities for our RAIs, and made them more accountable for care coordination that was happening within the region and what they were doing for our members. We also changed our payment model on the PCMP side as well. So recognizing that we could improve opportunities for our PCMPs to earn incentive dollars and pay them directly for earning certain incentives. Additionally, we put a lot into our ACC Phase 3 contracts to hold our raise more accountable. So while we had accountability mechanisms in ACC Phase 2, some of them were very blunt mechanisms. And what we did in ACC Phase 3 is actually put some performance standards that the raise have to meet as they're going forward with their contracts. And we hope this is going to improve transparency for our program, but also really strengthen the accountability of our raise. So if we go to the next slide. One of the big changes we had in ACC Phase 3 was changing our regions. So in ACC Phase 2, we had 7 regions. We've now put that down to 4, and that was really in response to stakeholder feedback, where we heard from providers and from members that could often be challenging working with 7 different RAY regions. So now we have 4 different RAY regions. You'll see on the map here, the blue area is Rocky Mountain Health Plan. So really our mountains over to the western slope. The region 2 is more of the Eastern Plains region. So goes all the way from Mid-Larimer down to Baca County, and it captures the Eastern Plains. Region 3 is CCHA, sort of that in the Denver or Boulder, El Paso region there, extending up into the mountains a little bit. And then Region 4 with Colorado Access is more the Denver metro region. The other part of this is we have 2 managed care organizations. They're a little bit different entities than our RAYs, but they're carved out of our RAY regions. So Rocky Mountain Health Plans has a MCO called Rocky Mountain Health Prime. And then Denver Health Medicaid Choice operates in the Denver metro region as well. So this is the new map. We hope this is going to be beneficial to our providers, really streamline some of the administrative work. A key thing for this group to note is this aligns with the BASO map. We heard over and over again with the MCOs, or not MCOs, MSOs, and our ASOs that there was an alignment with the RAYs. So one of the very intentional things that we did working with BHAAC is to make sure our maps were the same so that there was a lot less confusion for stakeholders, for providers, for our members, that sort of thing. If we go to the next slide. So some key overall changes in ACC Phase 3. There are a lot of different things in our contract, but we boil it down to 4 really critical things. The first relates to attribution. And so attribution is the process where we connect our members with a medical home or a PCMP. In ACC Phase 2, we were sort of forcing connections between members and PCMPs, even if there was no relationship pre-existing there. In Phase 3, we're ending what we call geographic attribution, and then putting the responsibility on the RAYs to help members find a PCMP. So it's a change for our PCMPs, it's a change for our members, but we hope that'll better reflect where members are receiving their care. Second, I sort of alluded to this earlier, but we've changed our payment structure for PCMPs. So a lot of the incentives will be flowing directly to the PCMPs for work that they're doing with our Health First Colorado members. And we hope that'll better incentivize our PCMPs and allow them to receive payment for higher quality care. The third, again, I alluded to this earlier, but we have more mechanisms now in our contract to hold RAYs accountable. Again, this was a response to stakeholder feedback where we got a lot of questions about what are we doing to make sure RAYs are fulfilling the obligations of their contract. And rather than just making it, terminate the contract sort of situation, we thought there were things that we could do to make RAYs financially accountable for the work that they're doing. So that's a key part that we'll be starting and that we've been working with the RAYs to make sure that we're fully implementing starting July 1. And then finally, we're doing a lot in ACC Phase 3 related to data and how we're collecting data from the RAYs, through a deliverable process, getting data files back to better track what's going on with our members and our population health so that we can better tailor our services to serve our members. So those are the broad categories. I could go into more details, but just to give you the big picture of what's happening with our new contracts. Go to the next slide. So I wanted to talk a little bit about care coordination and some of the ways that we're coordinating with the BHA and the RAISE and the BASOs are coordinating. If we go to the next slide. So as I mentioned, care coordination is a big part of our contracts, our responsibilities that we put on the RAISE. And in phase 3, there are a couple places that we're strengthening our contracts. First, we're looking at that transition of care, making sure when our members are going from different providers to different providers or different modalities or different types of services, that they're supported throughout the process. I think everybody on this call knows that it is very challenging to navigate the healthcare system. I feel like I work in healthcare and I have a difficult time navigating our system. And we want to make sure that our most vulnerable Coloradans, the people that we serve, are supported throughout that process. So we've added a lot into the contracts to make sure RAISE are constantly supporting our members, including our most vulnerable, highest acuity members. Second, we're implementing a three-tier model for care coordination that we're aligning with the BASOs. So the 3 tiers reflects the different acuity levels of our members, with the highest acuity members getting the most supportive services from our RAISE. So we've added in expectations for that high tier level and the middle tier level around outreach to members, making sure our RAISE are responsible for contacting these members to ensure that they're supported throughout the process. Third, we're asking our RAISE to coordinate with all the different entities that are doing care coordination. So we know the BASOs are doing care coordination. We have case management agencies. We have lots of entities in the state's providers do care coordination. And we're asking our RAISE to make sure that they're coordinating with all these entities as members are seeking these different types of services to make sure it's not confusing for members, that they know where to go to get appropriate services. And finally, we're improving our monitoring and oversight of the RAISE throughout this process. So we're getting more data back from them about their care coordination. We have higher expectations, and they'll be reporting it to us. If we go to the next slide, and I see there are questions in the chat, and we have a couple more slides, and I think maybe if we go through those, I can respond to some of the questions at the end. So as I mentioned, we have our expectations around care transitions. So we've asked our RAISE to form agreements with all the different entities that might be involved in the care coordination process, whether it's hospitals, emergency departments, residential programs, nursing facilities. And the purpose of these agreements is to, A, better share data as members are moving back and forth between systems, but B, to ensure there are processes in place so that they know what to do as members are toggling back and forth between the different systems. And so we want to make sure those are formalized agreements so that everybody knows what their role is in this process. Next is we're setting expectations on what best practices might be for care transitions. So we're putting those into contracts. We're having lots of ongoing conversations with our RAISE. But essentially what we're talking about here is what should their care teams be doing when they're working with a member? When the member is transitioning, when they're discharging, where the RAISE should be going for information, who they should be interacting with, what types of plans they should have in place for these members, those types of things. So I think this is all part of the process to improve this care transition process for our members, because we've heard there are lots of times where members have been lost in the system. They discharge, they don't know where they need to be going, they're not following up in their care. And for our highest acuity members, that can really mean significant impacts on their health outcomes. And so by putting RAIs into this process, making sure they're coordinating with all these different entities, we can improve the outcomes for our members. And then the third component here, Katie, if you want to get to the last one, is enhancing our expectations for monitoring for the RAIs. So, I should say enhancing our monitoring of the RAIs. So, we've been collecting lots of information from the RAIs throughout ACC Phase 2, but we're really upping our game, I think, in ACC Phase 3. So we've learned some lessons about what types of information we need to collect from our RAIs. So we'll be doing that through deliverables and data file shares. Like I said, we'll have new performance standards in our contract that the RAIs will be adhering to, and a lot more things that we can look at to see how it's working throughout our state. If we go to the next slide. I mentioned we're doing a tiering process with our RAIs, and again, we're coordinating with the BHA on this. So at the lowest level, every member has access to care coordination, whether they're a high acuity member or not. So our tier 1 reflects that, where if members need care coordination, they need help navigating the system, they can go to their RAI and get access to that care coordination. Our tier 2 is for members with rising risk. So working with our RAIs to identify members who maybe have conditions that, if left unmanaged, could really escalate and cause more significant problems. Making sure that their chronic conditions are better managed, that they have access to condition management programming at the RAIs, that type of thing. Tier 3 is our highest acuity level members. And that's where the expectation on the RAI is to go out there, actively outreach these members, and make sure they're addressing complex needs that they might have. These are the highest cost members, but more important than cost, these are the members that we identified with really significant healthcare challenges and really need assistance navigating our system, getting the most appropriate care. We think by doing this tiering model, we can be more intentional on how we're serving our members and outreaching those who really are needing the most services from the department. If we go to the next slide. So I mentioned we've been collaborating with BHA, and our expectation is that RAIs and BASOs will be collaborating as well. So we've already started, we've had regular meetings with the BHA. Our RAIs and BASOs are meeting as well. They're forming agreements to work with members who might be going back and forth between the two systems. But essentially, we want to go into this making sure we have the highest degree of coordination between all the different agencies so that our members aren't responsible for figuring this all out. So the expectation here is that our RAIs and BASOs will have workflows back and forth and formalized data sharing agreements so that members who are toggling back and forth between the system can do that seamlessly. We want to make sure that whether it's a BASO or a RAI interacting with a member, they have access to the same level of care coordination, and that as members get disenrolled from Medicaid and are working with a BASO, there's a continuity of care that happens there as well. So these are ongoing conversations between the two agencies, and really we want to make it seamless for our members once we hit July 1 so that they're not noticing a difference or noticing improved coordination as they go through all the different systems. We go to the next slide. Some of the monitoring that we'll be doing in oversight, we have been modifying some of the deliverables we're collecting from our RAIs so that we're getting better data about how they're doing care coordination. We also have a FDE who will be responsible for working with the quick care coordination teams at our RAIs. And the entirety of her job is to go out and monitor the RAI care coordination teams to see how they're implementing our programs. I've talked a lot about the performance standards in our contracts. there are actually financial implications for the raise if they don't meet those performance standards. And so we'll be holding them accountable throughout the duration of the contract to make sure that they're adhering to our standards, and if they don't, there are financial implications for them. In addition, we have key performance indicators for the raise that relate to care coordination as well as the outcome or the population health outcomes. So there are a number of different ways that we can monitor our raise and hold them accountable for the work that they're doing. If we go to the next slide. I just wanted to talk briefly about how we are supporting our rural communities in ACC Phase 3. So if we go to the next slide. Really a key goal for us is to make sure that every member, whether they live in the Metro Denver region or if they live in Ouray or Weld County, has the same sort of access to care. And so another thing that we've been doing in ACC Phase 3 is trying to strengthen our rural provider network. There are a couple of ways that we've been doing that. I mentioned our raise are responsible for practice transformation. So they're responsible for going to all providers and making sure they have the infrastructure to implement our state Medicaid program. A lot of the emphasis will be with our rural communities, and because we have a regionally based program, that really frees up a lot of resources for our rural counties with access to care issues. We also have done things with our primary care medical providers, or PCMPs. So we have what are called access stabilization payments that are available to small and rural PCMPs. Also putting resources out there like condition management programming from our raise that can go to our primary care medical providers, and using other tools like e-consults to provide access to specialty care. So we know there are a lot of challenges in our rural communities. It's something we're very aware of and something that we're working to improve on. Because our raise, like I said, have regional boundaries, they have insight to the unique needs within their regions. And so we hear from our raise all the time where there are opportunities for us to support the providers in their region. They often have other funds that they use to support rural providers. And I think it's that flexibility that we have that we'll continue to build on in ACC Phase 3 to make sure that we're building a network across our state, not just within specific areas of our state. If we go to our next slide. That's all I have in my formal presentation, but I'm happy to respond to any questions you might have.
Thank you for that. Matt, that was a great presentation. Jamie Ulrich.
Hi, Matt.
Hey, Jamie.
It's been a long time.
Yes, good to see you again.
Good to see you. Thanks for the presentation. I did have a question on your slide when you talked about the agreements between the entities. And I saw that you listed out hospitals, EDs, residential nursing facilities, crisis providers. And I wonder if you would consider also agreements between county departments in that list. I think, and again, I speak on behalf of all counties, not specific to my county, because we have within Weld County Department of Human Services what we call clinical care coordinators who are who really have become experts in Medicaid to fill the gap as it relates to child welfare involved youth. But many counties don't have that. And they really rely on the expertise with their raise in order to help them navigate when we have a child in child welfare custody. So would there be an opportunity for there to be a more formalized agreement between the raise and the county departments of human services that would show the collaboration and the assistance to walk through the needs that we have for that specific population?
Yeah, thanks for the question, Jamie. And, a couple of things. We do have in our contracts currently requirements that they work with their health neighborhood, which includes counties. There are also counties that operate as case management agencies or human service departments that operate as case management agencies. where there is an expectation there of formalized agreements. I think my general answer is we want to push them to have agreements wherever those agreements are important. And so, you and I have worked a lot on child welfare issues, and, where there is opportunity to improve outcomes for our members by having agreements that allow data sharing, I think our expectation would be the raise they do that sort of thing. And I will have to go to our contract. I'm trying to remember if we have like 500 pages of contracts. So I'm trying to remember if there's something specific about formalized data sharing agreements with counties or not in there. There very well could be, but that's a question I could get back to you on. But I think my broad response is if there are opportunities to improve coordination for our members, our raise should be entering into those types of agreements. And oftentimes they will. There are some tricky parts of it where we have like enrollment and eligibility components within counties, or counties doing the eligibility and enrollment, and our raise can't do that type of work, and so we have to be careful about that. But for the issues that you work on, Jamie, certainly those types of arrangements seem valuable to improving the care for our members.
Thanks, Matt. I appreciate that. I'm happy to work with you on this.
Yeah.
I would love to see if we can find, if it is in the contract, and if it isn't, if we could set the expectation that those agreements are created. I just want to make sure that the raise are not stepping out when a child becomes involved in the child welfare system. They need to come alongside. Thank you.
And I think, you've been involved in the system of Colorado system of care or Medicaid system of care conversations, and that's a huge part of that conversation and how we're working collaboratively on that. So absolutely, there's a great emphasis on the raise for implementing that and working on those issues going forward.
Great question, Jamie. Thank you so much for that. And Danielle Angadi. And we have 1 minute till public comment, by the way, just to let you know. Danielle, go ahead. Danielle, do you have your hand up? There we go.
Can you hear me, Tasha?
Yes, we can hear you now.
I was just going to say that I just wanted to make a comment in support of the raise based on the comment of we want to make sure the raise aren't stepping out when CPS gets involved. And I just want to say, as someone who plays heavily in creative and complex solutions, what Boots on the Ground has actually shown is that the raise are not the problem. It's CPS and every other agency that starts to back out and walk away and hand it to the raise and say, here's your job. And so where we see the lack of collaboration is not from our raise or the bossos. It's actually from your child welfare. It's your MSTs, it's your high fidelity wraparound. The minute that everything's handed over to a complex or creative solution, everyone starts to back out. And so I think that there probably needs to be some clarity on all sides what the expectation is, because we're even seeing CMAs back out at this point the minute it's handed to the raise, and I think that's unfair and untenable. So what I can say in the two raise that I'm working heavily with, they are actually our shining stars, while everyone else is kind of a nightmare.
Thank you so much for bringing that up to the, I don't know what I'm trying to say right now. Thank you for bringing that to the attention and your input on that. It's greatly appreciated. Thank you, Danielle. And at that time, it is 10:26. If we have any other questions for this presentation, if you guys could like put those together and email them to Megan Shelton or to Matt, if you can, however, I don't know how you want to coordinate that, Megan, so we can get all the answers or the questions answered that people have about this presentation. I greatly appreciate that. It's now time to move on to public comment. I want to thank Matt and Katie for being here today. It was a great presentation. We greatly appreciate your presence here at the Behavioral Health Administration Advisory Council.
Thanks so much for having us.
Thank you.
All right.
All right. Thank you. Megan, do we want to open it up for public comment now?
Yes, please, Tasha.
All right. So now is the time we're going to open this up for public comment. We have 2 attendees. Judith, would you like to take over? I'm trying to read chat and all that other stuff. So, yeah.
Absolutely. Should I allow them to talk or?
Yes.
Oh, I will do that. Okay. I have Teresa.
Hi.
Hi.
Can everybody hear me?
Yes.
Okay. Well, Teresa Cobley is my name, and I am a bereaved parent. I've lost 2 sons to the overdose crisis, and I'm a very active participant in the Boulder Substance Use Advisory Council, co-chair of their legislative and advocacy group. And I wanted to update this group on some of the initiatives that we were going through. I have started actually something called Spencer's Initiatives, and it's based on my lived experience. My son's name was Spencer, but it also is an acronym for Safe, Patient-Centered, Evidentiary, Needs-Based Care for Effective Recovery, and it has a bunch of recommendations for reform, systemic reform, and legislation. And while the BHA is looking to write a report and maybe get a legislative agenda for next season, I thought that I might share the work that I've done on this with you all so that you can benefit from some of the insight from lived experience. And I'll mention that I've written it with colleagues. I have an addiction medicine doctor, Jim Schuler. I've got Jose Escobil from the consortium, who's also signed his name to it, and Trina Fates, who is a community activist here in Boulder. And we've all signed on to this concept paper. We've also gotten some commentary from people at the BHA as well as the regional HHS. But given what's been happening in Washington, we kind of are at a standstill with talking to those regulators right now. And I am working with a national recovery advocate called Ryan Hampton from Mobilize Recovery to get some of the concepts heard on a national level, because primarily this is my initiative is calling for better standards of care in the treatment industry and amongst sober homes, and use of patient safety practices, a discontinuation of administrative discharge, things like that. And it's too long to get into right now, but my ask is, who can I send my information to so that people can learn from it? I'm certainly willing to engage you further in the ideas or become part of the conversation.
Thank you, Teresa. If you can send me your email, I can connect with you after this meeting. We do need to limit public comment to 2 minutes per person, and we have 1 minute left. So I do want to move us along. But Teresa, please email me. I will put my email in the chat, and then I'll respond to you, and we can set up a time to connect offline.
Thank you.
Thank you so much for that, Megan. I was just typing to see if we could get that information sent to you so we can get it out, because I know there are some other members that would be definitely interested in that. Next public comment is that Megan, I believe?
Russia had her hand up,
Okay.
and then Megan.
Okay, thank you.
I think I unmuted Russia. Yes.
You can come off mute now.
1 moment.
Okay.
I think I have now.
Yes, she is
Give me a moment. Okay.
off
Thank you.
mute. Go ahead with your comment.
Hi, everybody. My name is Russia Nauer, and I'm the director of the MindSource Brain Injury Network. Judith, it's really nice to see you again. I thank you guys so much for hosting these advisory council meetings. It's great to always be here. I heard a lot of conversation today about serving populations of folks who continue to face multiple both behavioral health and physical health needs, and people who struggle to get care in rural settings, and how the BHA is trying to, using the Accountable Care Collaborative, address people's needs, multi-system needs, through contracts with BOSOs, RAISE, and the ACC. One of the things that I want to make sure that I highlight is that the same folks, same groups of people will have very high rates of brain injuries. They will likely have their brain injuries unidentified, and they will continue to fall through the gaps of being able to engage successfully in services that the BHA and other organizations are trying to make sure that those gaps that are trying to be closed. And we know that with proper brain injury screening and brain injury informed services, that it is much easier to engage people in care. And MindSource has free screening. And so I've gotten to talk to Judith about this, and she's working with us a little bit on this, but I want to be really open about how easy this would be if we could add this to contracts, and how easy it would be to make sure that agencies use the screening that MindSource already pays for and shares our password, so that people can get screening and get training. The BHA has training about brain injury screening that has already been created and is in the learning portal. Everything's right there for the taking. And so I would love it if there was further conversation about this being included in contracts, and that's a basic expectation for people to get screening for brain injuries, regardless of how they're entering our various systems, so that we can provide them the care that they need in the way that they need it, and will respond to it best.
Thank you so much for that, Russia. And from somebody who is a person a survivor of a brain injury, I appreciate you bringing this to us. Is there by any chance that we could get your contact information, or Megan, however we can coordinate that, so we can get this address, see this further, because this is a really important piece that she speaks of, with people with brain injuries and not getting the care that they need. So I appreciate that.
Thank you, Russia. And Judith and I will be in contact with you. Thank you for putting your email in there. Megan, thank you for putting your question in the chat. We are over time, so we do need to close out the meeting. But we will ensure that we are covering these questions during our review of this presentation on June 12th.
Yes. So thank you. And on that note, that comes to the conclusion of our meeting for May. We'll be in contact with members for other information that comes up. I can't think of this, but I submit to adjourn this meeting. All right. Meeting adjourned. Thanks, guys. And you guys have a great month. And I appreciate you all being here.
Thank you.
Thank you. Bye. See you next month.